I'm going to talk about multimodality imaging and left ventricular assist devices. So my role here is to talk more about echocardiography, and Dr. Chang is going to talk about CT. And what I've done is, in the initial part, I'm going to talk a little bit about just what I expect from an echo when it's read from an LVAD, and what am I expecting in terms of images. We have sonographers here that I worked with, and the way I think about echocardiography in LVAD patients is a point of care test. So when we order an echo, we're making a decision right there and there about what we're going to do with the LVAD speed or what kind of complications we're dealing with. So most times I would encourage all sonographers to just give me a call when you're at the bedside. And we've done this with multiple sonographers, and we've got really good things on echo, which I have some images for, and we can talk about those a little bit more. So when do I need imaging in LVAD? So number one is when somebody has an LVAD, I want to assess whether they're effectively unloading or not. Assessment of regurgitant lesions. And the regurgitant lesion I'm going to focus on is going to be aortic regurgitation predominantly. The third one is obvious, looking for clot. We've all been through the ramp studies for pump thrombosis, and we'll talk about that as well. And some nuances. I mean, some things have changed, and some things we are learning more about with all these devices. RV dysfunction and RV failure is a bane of our existence, and that's something we're always very interested in. And some of our patients who are acutely ill is because of RV failure or RV dysfunction. And then troubleshooting alarms is a big one. The two alarms that are common are low flow and suction. And I'll go over case examples of those and how we troubleshoot those alarms. So current devices, we all know HeartMate 2, HeartWare, HeartMate 3. So now HeartMate 3 is also destination therapy, but all of them, the difference between HeartMate 2 and HVAD and HeartMate 3 is that HeartMate 2 is an axial and it's preperitoneal, whereas the HVAD and the HeartMate 3 are centrifugal and they basically sit on your pericardium. Whereas the HeartMate 2, the cannula was inside the LV cavity, but the pump rotor sits preperitoneally. The LVAD speeds are variable, so when you walk in the room, fellows should be able to tell which device the patient is without knowing what device it is, because the speeds are different, right? So if you have somebody who has a speed of 9,000, you know instantly it's like HeartMate 2, right? If you have somebody who has a speed of 2,600, 2,900, and the console is very different, that's an HVAD. Somebody has a HeartMate 3, the usual speed that we keep people at is around 5,000. So those are the differences in their speed. The upper limit of HeartMate 3 is, they say 9,000, but it can go up as high as 11,000. Yeah. Okay, so one is not enough, by which I mean one modality is not enough for LVADs. LVAD assessment is a little bit complicated. It's a composite of looking at your patient, hemodynamics, and then echo, and then CT. And we use CT in our center a lot, which has been extremely helpful in understanding what are the different complications of VADs that occur. So what is LV unloading? In my mind, and this is my definition, that effective unloading is a speed where the LV hemodynamics are optimized, meaning that the LV size is small, you have a pulmonary capillary wedge pressure that's normal without compromising the RV hemodynamics too much, where your wedge and RA ratio is within reasonable range. You're not flooding the RV, you're reducing the afterload, but at the same time, the septal interaction remains okay and there are no suction events. And I didn't appreciate the septal interaction as much as now I've seen acute RV failure, and I have an echo about that. Understanding that keeping the septum midline plays an important role also. So what are typical echo features that are consistent with inadequate unloading by LVAD? Obvious ones are dilated LV and LA enlargement. Now some people would have like a dilated LV regardless of what speed they're at, but when we do hemodynamics on them, they're okay. What I do encourage everybody is to look at the pre-implant echo also. Like if somebody has an LV cavity that's 9 centimeter in size, you're only going to reduce so much before you get to a point where they have effective unloading. You also want to make sure like what their inflow cannula is looking like. It's not impinging on any of the walls and pulling in the mitral apparatus. Now, if you have persistent mitral regurgitation, which is greater than mild to moderate, I would say that's also a sign that you're not effectively unloading. But be wary of mitral regurgitation again, because sometimes you're pulling in the mitral apparatus, actually causing iatrogenic mitral regurgitation, which is not a sign of ineffective unloading, but actually because you're sucking in the mitral apparatus. Again, systolic PA pressure is greater than 40. We use the TR jet, and elevated RA pressures are something that we would like to know about. And the mitral valve E to A peak Doppler velocity greater than 2. So this was a study done here actually by Dr. Naga and Dr. Estep combined, looking at echocardiographic evaluation of hemodynamics in patients with systolic heart failure. There are around 50 patients or so that they had concomitant right heart catheterization and echo on. So we looked at what would be accuracy of echocardiographic parameters to predict a pulmonary capillary wedge pressure of greater than 15. So and it's pretty intuitive. It's the same thing as you would expect for any kind of person who has systolic heart failure. That things that you know about, we can apply the same things to our LVAD patients, like RA pressure, the systolic PA pressure, the LA volume index, the E to A ratio. These are all things that we generally do for other patients also, and the same algorithm applies. So they came up with this algorithm, which is that if you have somebody who has persistent heart failure symptoms in the presence of continuous flow LVAD, then the algorithm that you apply is that you look at the mitral E to A, then and if you have less than equal to 1, any one parameter like RA pressure less than 10, LA volume index less than 33 mLs per meter square, or E to E prime less than 14, you're pretty much dealing with somebody who has a wedge pressure that's normal. Although one caveat I would say, on hemodynamics in the cath lab that I see very often, your wedge could be completely normal, but your RA could be big. You could be dealing with RA pressure of 20, and those are people with some degree of RV dysfunction that continues. So I wouldn't say that if you have RA pressure that's high, that they have high filling pressures. Rather, they may be somebody whose has RV dysfunction. But I would say more so if your LA volume index is okay, if your E to E prime is less than 14, your E to A ratio is okay, then I'm thinking more on lines of somebody who has normal filling pressures. Now again, the same thing, if you have these derangements, RA pressure greater than 10, systolic PA pressure greater than 40, LA volume index greater than 33, E to E prime greater than 14, you're dealing with somebody who has pulmonary capillary wedge pressure greater than 15. So for sonographers, I mean, I really appreciate if you do the inflow velocities on them and try to do a reasonable job at it. One other thing that I've noticed now and I'm going to say this because I'm mentioning the tissue Dopplers also, is that with these pre-pericardial or the centrifugal pumps that are sitting on the LV cavity, we've seen some constrictive physiology also and interdependence, which we don't completely understand the effect of on the patient's hemodynamics, but we've seen that when that sets in and they have some kind of constrictive physiology or some restriction, they do not unload adequately or have more RV dysfunction also. And that's something that I want to look into further, so just try to get good tissue Dopplers and inflow velocities for us. So this is an example of somebody who has a normal estimated pulmonary capillary wedge pressure on LVAD support. And this is concomitant hemodynamics and echo. And this, as you can see, the E to A ratio, the tissue velocity is expected is low. The PS systolic pressure is okay. So this is somebody who had a wedge pressure that was around 9. And then somebody on figure 2 that's elevated pulmonary capillary wedge pressure greater than 15. E to A ratio, and then PS systolic pressure, as you can see, is high. The fun part is in the cath lab, we can keep increasing the speed, and we actually see a meaningful change. So you see it right away that, okay, the TR velocity changes, the E to A ratio can change, the wedge becomes normalized, and we can capture all of that at the same time. So why, one would wonder why you would have ineffective unloading when you already have a VAD. It's a little complicated because sometimes, the inflow cannula position can be such that you cannot increase the speed too much, and then you're left with somebody who has some degree of heart failure because the septal interaction was not allowing you to increase the speed. If you have a low set pump speed anyways, sometimes when they come out of the OR, we run them a little bit low, like for HeartMate 2s, we'll not run them at 8,800 so that the heart can get used to that speed and then slowly ramp up the speed. They can have clinical heart failure. If you have hypertension, big deal. So one of the things is, and I would ask fellows to focus on it, when you're reading an LVAD echo, look at their MAP also. Because if their MAPs are high, you're dealing with hypertension, and that could be a reason, that could be modifiable. at the time of the echo, like you do for MR. You know how everybody knows what the blood pressure was when the MR study was done. Similar is for LVAD, it's important. Inflow cannula malposition, big area of contention. Nobody knows how to define it. What is appropriate inflow cannula malposition, and we're working on that as well here, trying to define it better with hemodynamics and inflow cannula angle positioning. Pump malfunction is also, it's becoming less and less. We see less pump thrombosis, but we still see it. And I'm going to talk about this a little bit more because I feel like it's not as intuitive as one would think if you're reading it in the echo lab alone. And then if you have aortic regurgitation, that's a big contributor to ineffective unloading because of a continuous slope, and we'll talk about that a little bit more. So now I'm going to talk about the second thing that I'm interested in when you're reading an echo that I order in LVAD patients. So the first one was, of course, clinical heart failure and those hemodynamics. The second is aortic regurgitation. We know that if you have aortic regurgitation that is moderate to severe, quote unquote, because I don't know what the definition of moderate to severe is here, and nobody knows. And I'm going to talk about some of the newer literature that has developed over this, of trying to devise a method to quantify aortic regurgitation. That's a big area of, it's a black box, and we don't know what's the gold standard to go against. But if you developed AI, you're going to have more hospitalization, there is more risk of mortality, and these patients over time don't do well. And then we look into strategies like TAVR in these patients, or a Park stitch, which is where you just put a stitch on the aortic valve so there's no leakiness anymore. So it's a significant contributor, and we do see that when we keep increasing. I have a beautiful hemodynamic tracing coming up where somebody who has AI and they cannot unload no matter how much speed we're at. So why does that happen is because if you have a aortic regurgitation loop, it becomes like a closed loop, and despite increasing the flow, you just have so much leakiness going on that you cannot unload effectively. And it can range from anywhere from 15% to 49% of people develop aortic regurgitation over time. So AI is bad, and the definition that's being used in the AI guidelines is still there. We're extrapolating from what we know of AI, just the vena contracta or the jet width, LVOT width greater than 46% is thought to be significant AI, but to be honest, I don't quite agree with that. And I think that needs to be taken with a pinch of salt, because it really depends on what your LVAD speed is at, what's the LV cavity size, what kind of hemodynamics do we have. So it can't be that the same vena contracta at 8,000 RPMs means the same amount of regurgitations if you're at 11,000 RPMs. That's just very intuitive. That just makes sense. This is somebody, so we do usually think that AI develops over time, and that this is an example of somebody who had 1 year post in 2010. They were doing okay, NHY class 1, no heart failure admits, doing well. 2 years, start developing some AI. 3 years, develop significant AI. Although I would say now that I've seen early AI. So that whole notion that it develops over time is also something that I think is variable, and it's changing with different VADs that we're using. Why that occurs is that they have, in pathology studies, they've looked at the cusps, and the cusps over time kind of fuse and they form holes. So one of the things that we're looking at is CT may be also helpful, because you can see cusp fusion on CT scan if you have a good CT scan. So again, if you have somebody who had mild AI and their LV diastolic dimension 3.7, somebody who had severe AI, LV diastolic dimension was 6.8. So this is somebody who then underwent TAVR procedure. There's this new paper that came out, and this is the best we have. And feel free to criticize this, because it is extremely variable and I think prone to error, and this is what we have right now. This is the best we have. So imagine how much work can be done to improve this. This is a paper by NeuroReal in Chicago, and they look at, they're calling it accurate quantification method for aortic insufficiency in patients with LVAD. They used hemodynamics as well as echo in patients with AI. And so the way they're quantifying the regurgitant fraction is they're looking at the total systemic flow minus the flow to the right side of the heart. So the flow to the right side of the heart, they used Fick method to quantify how much flow there was. And for the total systemic flow, they're looking at cardiac output from the VAD itself. So how would you look at the cardiac output from the VAD? By looking at the outflow cannula and looking at the TVI from the outflow cannula. How many times have we seen good outflow cannula images? Very few, right? So that in itself is a hole there. And the second thing is then LVOT TVI, right? LVOT TVI, I'd say, is reasonable, right? But then we have to look at the relationship, whether they have aortic opening. How many times does the aortic valve open? So it can be intermittent. So that has not been accounted for here. And so they combined the VAD flow with the aortic valve flow and minus the cardiac output from the right heart cath, and that's what they're calling the regurgitation fraction. Yeah, Nadine, I like the face you make. Yeah, but it makes sense, but I think there's a lot of room for error, but this is the best thing that we have so far. They also looked at something, the diastolic acceleration and the diastolic and systolic ratios to determine whether that could be used in looking at regurgitation fraction. And this is a nice table, kind of summarizes that if somebody has their mild or trace AI with the regurgitation fraction of 26%, their systolic to diastolic ratio was around 6, and their diastolic acceleration was 35.7 centimeter per second square. And the wedge was around 10. So they did hemodynamic corroboration with it, which gives it some, I would say, you can rely on it a little bit, but I think still there's a lot of room for error. Now, they're calling moderate to severe AI somebody who has regurgitation fraction around 40% with a systolic to diastolic ratio of 2.6 and diastolic acceleration of 68.7 centimeter per second square. So could we use the outflow graph? It would be nice. I mean, I think we should, as a echo lab, look at the outflow graph and try to get better images. So that's and do pulse phase Doppler across it. And in my last section, I'm going to talk about ICE, and I think this whole issue with outflow graft, where we can get extremely good images of outflow graft, is actually only through ICE and do Doppler across it, and I'll show some images of that. The next one is pump thrombosis, and I think I have a problem with how we diagnose pump thrombosis. I think pump thrombosis is a diagnosis that you make truly by hemolysis panel. You have a rising LDH without any other cause and a plasma-free hemoglobin that's high and a urine that shows blood, you have hemolysis. Now, whether it's the struggle really is the clot occlusive or not. When we do the RAMP study, only when you have a completely occlusive clot will you see those changes that over time, if you keep increasing the speed, the aortic valve will still open and the LV and diastolic dimension will not shrink. That's only for occlusive thrombus. So between no thrombus and occlusive thrombus, there is that category of partial thrombosis. And partial thrombus, I mean, you could still unload. It's not going to give you any meaningful information from the RAMP, and that you have to just follow clinically. So I know we order a lot of RAMP studies and they're painful, but the idea is the only thing that it can tell you is whether or not if it's a completely occlusive thrombus or there's a partial or no thrombus. It doesn't discriminate between partial thrombosis and or no thrombosis. So that you have to do clinically. So my two questions to myself have been, how good are we proving pump thrombosis by echocardiography or by comprehensive hemodynamic studies? Not very good. We're not able to discriminate. And to be honest, if somebody is completely clotting off their pump, I can tell you at the bedside. And how good are we stopping the propagation of pump thrombosis is another question, which still needs further answering. This whole idea of RAMP study is also done by Nero Real, who came up with a novel technique of this RAMP study of capturing images with the peristernal lung, looking at the LV and diastolic dimension, the aortic valve opening, the deceleration time, and doing it progressively each different speed to see what happens with each increment. Because like I said, the changes that you see with LVAD on the heart are right there, and then you know what's happening. And then they looked at this RAMP study slope, which is that LV and diastolic dimension ratio to the incremental speed changes in the LVAD could predict LVAD malfunction. So Dr. Estep then simplified this, and this is from our center, that if you had an LV and diastolic dimension with incremental speeds, at let's say if you started at 8,000, you had an LVAD and diastolic dimension of 6. At 11,000, you had 4.5. That shows that you can see that there has been a decrement. And that decrement doesn't occur, then you know that you're dealing with somebody who has occlusive thrombus. Also the aortic valve opening time, the right-sided cardiac output, with incremental speed, your cardiac output on the right side should also increase. So one of the other things is that on our LVAD patients, we do want a nice RVOT if at all possible. I know sometimes they're difficult to image, and then a nice TVI through the RVOT. And then the mitral valve deceleration time. So this is how the LVAD RAM study is done. Now, caveats to this. HeartMate 2 is a different animal than an HVAD is a different animal than a HeartMate 3. They do not behave the same way. So how HeartMate 2 has a linear relationship with incremental speed, you'll see the LV and diastolic dimension have a rather linear relationship, whereas an HVAD has an exponential relationship. So you can't see that with each increment is what expected LV and diastolic dimension is going to change. So it may not, and we don't have a ramp study or a paper on HeartMate 3s yet. So that's still something that's cooking, and once we have more information, we'll share that with the lab and modify our protocol more. So RAM studies, oh Lord, it's the same for the sonographers and for the echocardiographers, and I'm ready to take it upon me to do this. But one thing I want to do, the additional caveat. So this is a paper that came out recently. It's on RAM studies. Do loading conditions matter? And they do. So if you have an LV and diastolic dimension, that slope wasn't changed. Just putting it quite simply, if you had hypertension or if you have aortic regurgitation, you may not change that LV and diastolic dimension. And then you are stuck with a false positive study that you think that somebody has an occlusive thrombus, which may not be the case. So when you're reading these cases, and for sonographers too, I'd really appreciate if you put in the accurate map that they have from the nurses at that point in time, and the fellows, if they can put in the exact blood pressure they had at the time the LVAD RAM study was done. And then if also mentioning that this is somebody who has aortic regurgitation, which is significant, because the whole, it can just give you a false positive. And in this paper, the only discriminator is that if their LDH is high, then you're dealing with somebody who has pump thrombosis. If their LDH is low, then you're dealing with somebody who may have a false positive test. So then it becomes, eventually, a conversation with LVAD attending and whoever's rounding on these patients to know them clinically well. These are some of the nuances, and I'm not going to go in details of this because I have 74 slides to finish. So we'll So this was an example of a hemodynamic study that I'd done at Mayo, where this patient had aortic regurgitation, and if you look at their the red is their blood pressure. We had an LV catheter as well. That's the green one. The gray one, and then we had the PA catheters, the green one, and the wedge is the blue one. So despite us increasing the speed, the wedge doesn't change. So this is somebody who we try to keep on increasing the speed, but the wedge didn't decrease. And when we did a concomitant ICE on that patient, we found a significant aortic regurgitant lesion, which was not called out on the transthoracic echo. It's the same patient, even going up on speed, the wedge only decreases to 18, but never normalizes. And 10,200 is a massive speed for our patients. So, giving that context, if the wedge is not normalizing at 10,000 or 11,000, you're dealing with somebody who has a profound regurgitant lesion. And another thing is that, the whole hemolysis and pump thrombosis business is a spectrum. Patients can be completely asymptomatic but may have a clot there. So, when you're doing RAM studies on these completely asymptomatic patients, don't be surprised. But they can have any number of presentations, including cardiogenic shock and death. I mean, there was a patient that I had seen at Mayo where their presentation was cardiogenic shock and the pump had completely clotted off. So that can also happen. This is just an example of a normal ramp response at the increasing speed. As you can see, the LV and diastolic dimension is difficult to appreciate, but as you can see with the incremental speed, the aortic valve just closes off and doesn't open anymore. This is, again, normal, no, this is malfunction. So this is a patient who, on incremental speed, as you can see, the aortic valve continues to open. I also, again, to the sonographers, if M mode is helpful to us. And so also color M mode is also helpful because we can see AI color also. Again, this is somebody who had normal pump function. So this shows somebody who's E to A ratio and deceleration time kind of normalized with increasing speed. Somebody with malfunction, that relationship, of course, doesn't change. So this was a case that I recently saw, and RV failure, like I said, is the bane of our existence. So this is I think David was doing this case with me at the bedside. David, I think. So this patient was in acute RV failure with typical, what you would see is hypotension, cardiac index dropped, MAP was in the 50s, cardiac index was 1.2, but we managed to get some images just to show you what it means. So in the early postoperative phase, it can be the septal interaction, and that's really important. So let me see this. So you see this is the LV, and it's completely shrunk, and the mitral valve is completely just shifted towards that side, and the LA is extremely small, and the RV is humongous. And the whole septum is shifted off. So right there and then, with the sonographer at the bedside, I turned down the speed from 4,900 to 4,200, and this whole septum shifted right back. And within a moment, the blood pressure got better, the index improved, the flows improved. We didn't have to do anything else. No pressors, no nothing. So this is that acute of like I said, we use it as a bedside. Echo is our bedside friend. If this happens, we know right away what it is. What people, again, for fellows, when you see patients who have hypotension and low index post LVAD, people think this, hypotension, sepsis, let's start increasing pressors. And by the time I'm coming in, they've already injected methylene blue, which is the wrong thing to do for these patients. So what you need to do right away is just ramp the speed down, let the flow improve, let the septal interaction get better. If you have any confusion, you can get an echo and see what the septal interaction is like. And once just ramping the speed down in that phase will help. We'll worry about unloading later, because in the beginning these patients are supported. They have suppressors. We're giving them diuretics or an IV drips and those kind of things. So unloading is an issue that you deal with at the time of discharge. In the beginning phase, like I said, is the bane of our existence is RV failure. We want to make sure they don't have RV failure. So RV failure comes in different flavors. It can be mild RV dysfunction, which we will see in patients who are like we see clinically coming to clinic, and they have some lower extremity edema, some recurrent pleural effusions, and those are like some may have mild RV dysfunction. We usually don't do anything special for them. We'll just put them on some diuretics and those kind of things. Because, there's something that I really like what Dr. Butt-Fraser said, that, this is an LVAD, it's a left ventricular assist device. It can never fully support you. So you're still going to be on some kind of heart failure therapy. It doesn't solve the problem. You're not transplanting you, so you're still unsupported on the right side. The early postoperative severe RV failure, I think that first image that I had was much better. This is similar to that. You can see that the right ventricle is barely contracting, and then the septum interaction, it has shifted towards the left, and the RVs work. But that prior example was a better example because you could see the entire septum just shift and the RV ballooned out. This is also another example of RV failure. And then like smoldering heart failure. This is another thing that happens, and we're now the late RV failure phenomena is becoming kind of sexy in the world. We know that people have late RV failure, so we're defining that. We're coming up with ways to define it, and we sometimes do hemodynamic studies where we do fluid challenges, or we'll do a kind of a dobutamine challenge in the cath lab to see what their RV does, and we'll put them on long-term milrinone for late smoldering RV failure. What is the abnormality here? It's pretty obvious, right? I mean, I don't have to. This is a patient in the ICU post-operative that developed hypoxemia post-LVAD insertion. Any takers? It's pretty obvious. It's a PFO, right? And it just, at the time of post-surgical phase, it just became more profound with RV failure, and the patient was just hypoxemic, and everybody's freaking out. But once we did the study, we found that there's PFO, which is also another important finding. We should look for it pre-LVAD. I mean, we always do, but this is an example of how it was missed.
Yeah, but pre-LVAD, you can miss it because the LA pressures are too high.
Mm-hmm.
And the bubble will cross.
Yeah.
You have it. Now you have a very low LA pressure.
Yeah.
That's an ideal setup for bubble cross.
Mm-hmm. And a very high RA pressure in somebody who has RV failure also. Again, like I said, point of care testing. So this is somebody, you see the, I'm going to play this again. So this is somebody, the inflow cannula is here, and this is the myocardium. It's getting sucked into the LV cavity. This is somebody who came in with VT. So again, in these patients, you may not see suction when they're lying flat. So you have to make them do things that can reenact what exactly is happening. So this patient told me that when he shifts his position from back to side, that's when this happens. So I made him do Valsalva at the bedside, and I made him do exactly the same thing that he was doing. And sure enough, with that change in position, he had a full run of VT. He was about to get shocked, and then we knew that was the problem. So we ramped his speed down. And interestingly enough, he was also having rising LDH, because when you're creating a lot of suction, like let's say if every second or third beat you're having suction, you're creating an area of thrombogenicity. So his LDH also came down after we decreased his speed. Now, he was in clinical heart failure, so that's the imbalance there. We had to just put him on more diuretics. But this is a kind of my understanding of it. Somebody told me it looks like watermelon, but this is the septal interaction. If you have an inflow cannula, if you have change in position, I do think that with change in position, inflow cannula can change. And the other thing that can cause a change in overall inflow cannula position long term is change in weight. So that's one thing to look for. And then the other thing is, if you do Valsalva, then that can cause dilation of the RV, and that interaction can also illustrate suction events. So if you're really wondering if somebody has suction or not, make them do the change in position and enact whatever they think it does cause VT. Low flow alarms are another bane of our existence, but low flow alarms, can be because of RV failure, can be because of hypovolemia, can be because of tamponade, can be because of really bad hypertension, inflow or outflow cleft obstruction, and arrhythmias. The ones that I see the most is hypovolemia when they have GI bleeds. The other one that I see is RV failure. The one that we've been able to diagnose a lot here in our institution is outflow cannula thrombus and aortic root thrombus. For some reason, they also got a lot of low flows. So our protocol here is to do echo, make sure that his hemoglobin's okay, they're not bleeding, make sure their RV is okay. We do a hemodynamic study, and then we proceed on doing a CT scan. And on the CT scan, if there's a clot, I've diagnosed multiple of those, and Dr. Chang will show you some of the images of that. One other thing is that it doesn't take much for a VAD patient to actually go into tamponade. So remember that. So if they have even small amount of pericardial, kind of like hematoma that forms right after surgery, once we start the anticoagulation, that's the phase where they actually just liquidify that and then form like a small effusion. And even small effusions can be hemodynamically very significant. And that's kind of interesting from if you think about it, but I think it has to do with how the RV interacts with the LV. And we've seen that rapid improvement in their status once this even small amount of pericardial effusion is drained. This is somebody who had RV failure, and when we did inotrope and pump speed was decreased, then the low flows were resolved. And low flows, as you all know who've been on the service, hypertension is a big one for low flows. So that's the other one. Now I'm going to talk about ICE. Because we recently published a paper in JACC. It's an imaging vignette type of thing, but we have different images on ICE and how ICE adds a little bit more to the evaluation of LVADs. And we've used one or two cases now at Methodist also. So I'm just going to go over some of the basic views. When you first advance the ICE in the IJ or in the femoral vein, you go into the middle part of the right atrium via the IVC. You first visualize the RA, the RV, and the tricuspid valve. So this is and then I'll talk about how we kind of made modified views for VADs. Then if you turn the catheter clockwise, this is the kind of view you get. You get the aortic valve, RVOT, some of the RV. So it's kind of a long axis of both the pulmonary trunk and the aorta. Then in the low right atrium, you can get kind of a short axis kind of a view, and you just have to kind of like rotate it again. And this will give you the coronary sinus, the LA, LV, and the interatrial septum. And again, if you just then do counterclockwise, then you can get a very good view of the mitral valve. it's one of those things when you are in the cath lab and you're doing it, you kind of know, which way to turn around. But, these views take some time to get used to. And, I think most of our interventional fellows or EP fellows will learn how to do these. You can get a good short axis view, actually, in the ICE catheter also. So the modified LVAD views is what I call them. So our approach was to first look at the position of the interatrial septum. To be honest, I don't think the interatrial septum helps my thinking in any sort of way, but it's helpful to kind of see what the RA to LA interaction is and the pressures maybe somewhat, but I've not, I would say, clinically used it much, but this is a nice view to look at the LA and the RA. The one thing that was beautiful about ICE was the outflow graft, and I have some moving images also, as you can see, that we could actually see the outflow graft, and then you can see color Doppler, and we could actually run pulse wave and continuous wave through this, which is beautiful images. And you can actually, when you're kind of navigating the outflow graft with the ICE catheter, you can actually see most of the length of the ICE. This is the outflow graft, pulse wave and continuous wave. And it's not just this one image is nice. We always had nice images of the outflow graft. That was beautiful on the ICE. This is what I call the modified 5-chamber view for LVAD. So you could see aortic valve, of course, as you know, is very important for us. The aortic root thrombus, the aortic valve opening. So this patient had a root thrombus. Doesn't show very well here. LV size, you can look at that. LV-RV interaction and the position of the ventricular septum, and then the inflow cannula you can see here in the end, the relative position of the inflow cannula relative to the mitral valve. And then, one of the things that I'm interested in looking some of the VAD flow, but it's not very accurate. But here we can see RVOT flow better. So how we struggle a little bit with echo sometimes with getting the RVOT views. In ICE, you can get a good RVOT view. But the ICE doesn't give you a good LVOT view. And it can give you flow if you have aortic regurgitation, but you can't align the Doppler to get accurate LVOT TVI through it. So see how this TVI looks. It's probably not angled correctly, but the RVOT is perfect. Then this is the LV cavity. We used to call it the igloo shape because look at the septal interaction here. It's kind of tenting towards the RV, and the LV is huge here, but you can look at the mitral apparatus here. And then, again, one of my obsessions is the inflow cannula positions, but that also you can look at relative to the mitral valve. But again, the one thing that is inaccurate across the board is inflow cannular Doppler. So I personally have stopped believing in any inflow cannular Doppler unless somebody tells me that the patient's inflow cannula is completely off axis and you're getting completely, you're aligning perfectly to it. I've yet to see a good alignment. I mean, there are very few cases where, we show them in presentations, we talk about them, but to me, we've never been able to align properly to this. TR, not so relevant because, when we're doing, and, usually when you do ICE, you're concomitantly doing a right heart cath also, and with the 8 French sheath, with the same 8 French sheath that you put the swan in through, you can put the ICE catheter in through. So you really don't need so much PS systolic pressures and those kind of things, but it's a nice thing to see when you're looking at the TR jet and seeing how dilated the annulus is. This is a outflow graft obstruction. So this is, even though the size of the HVAN and they say HeartMate 2 or HeartMate 3 have a particular size of the anastomosis, but at the time of suture, remember, again, a human is suturing that in place, and they can be narrow. So this is somebody who, since the time of their LVAD, never unloaded appropriately. And when we looked at this dimension here, it was narrow, and when we looked at the velocities here, pretty high. 3.5, which is not something that you see typically of outflow grafts. Their velocities are not that high. Normal velocities are not that high. So we investigated that further, and we took this patient to the cath lab, and we put a pressure catheter through the outflow graft, and we looked at the pressure difference between the outflow graft and the aorta, and sure enough, there was a big gradient. So we did think about putting a stent in, and that's something that we do consider for some of our patients who do not have effective unloading despite all our measures. So if you have ineffective unloading, you have to think about some of those things. Then CT can help, but then again, the question is that, the kink, are they relevant or not? The aortic anastomosis, if you go to a surgeon, thankfully no surgeons in the room, they'll never accept that is something that's causing the problem. So the CT is helpful, this is helpful, but then putting a pressure catheter through here, like doing an FFR is that just nails it, that proves your diagnosis. So somebody with sepsis, with an interventricular septum, shifted to the left side with an underfilled LV. This is a good case of somebody had a descending aorta graft. So, if you have a descending aorta graft, there's not much retrograde flow. So this is the aortic valve, and you see there's a thrombus sitting here, and then this whole area is just stagnant flow. So we could see that very nicely on ice. This is a moving image of the outflow graft, and this shows AI on ice. And this final images of the inflow cannula. This is a nice image, but again, it's hard for me we couldn't Doppler it very well. That's all I have for now, and Dr. Chang has some CT images. I forgot about this. He's 40-20 distributions.
I'm going to reverse the order next time.
It's okay.
Can you use the mouse to start setting you up?
Sure. So what I do?
Continue without scanning.
What I do? Scan, continue.
Exit. Close all that out. Close all that out. Go to here. Scroll down. Go to removable. Not there. No. Go to remove. That shows right there on top. Just need a mic for the last
Sure.
one. All right, you all set.
All right. I think 10 minutes is good. Okay. Thank you, Mahwash. No. That's for the fellow who didn't stay late to read. I'm going to have them sit here and watch all the 185 slides. I know.
Start the slide.
But I will not. This one?
Yep.
Okay. All right. So real quick. So very nice talk, and CT has important role, and the main reason is this. You can see everything the echo shows. Basically, you're looking at the different ends of the LVAD device per se. Anything in between, for obvious reason, we cannot see by echo. That's why CT comes in to decide. If you find abnormal echo finding, if the CT can help you localize the abnormality and you can solve the problem. Okay, so the reason being, you can see the CT, besides seeing the heart, you can see the entire device, the pump, the outflow cannula, the inflow cannula, the anastomosis site. So this is a 2D display. You can have a 3D display. You can have 4D display if you want, which, okay, it's not playing, but it's okay, it's not that important. The overview, so basically for the fellows, when you look at a CT for evaluation of LVAD, you want to go systematically, look at the inflow cannula, outflow cannula. Inside the pump at this stage, CT cannot look through the metal to see what is inside the pump. But don't forget about the cardiac structure, obviously. Most importantly, the aortic root clot, I think is important. And obviously, we can see the surgical complications such as tamponade and with arrival of PET, CT for the infection as well. So this is kind of like what it looks like, the three major type of LVAD that we currently going to encounter. So the left-hand side, the HARMATE 2, okay? And the one in the middle is HARMATE 3, and the one in the right is the HVAD. So very different design. But the main difference, as Mahwash mentioned, is the location of the pump. One is intraperitoneal, the other one is the other two on the right hand side, the new one, are intrapericardial. And they all have distinct design. And this is what we want to look at, inflow cannula position. Ideally, you want to be kind of aligned with the mitral inflow for obvious reason, right? Because that's where the flow is going to go. And then you look at the I'm sorry. So the previous one, this one is the inflow cannula for HARMATE 2. This is HARMATE 3. And, I'm sorry, HVAD, this is HARMATE 2. So very different, obviously. And you can see the position of the cannula could be extremely variable. So the first one will be considered normal. One in the middle considered off axis, which we don't know what it means. And the one on the right is obvious, it's overt malposition. The whole entire cannula is stuck into the septum. And that would definitely cause what we call suction event. And this is what the case in Mahwash showed earlier. It's a different patient, but similar presentation. We have suction event and VTAP. And you can see the velocity through the Doppler velocity through the inflow echo was very elevated. So this patient obviously need to have the cannula repositioned. Okay, so the outflow cannula is extremely variable, especially for HVAD and HARMATE 3. HARMATE 2 is a little bit more predictable. So this is how it looks like, a normal cannula position straight up all the way to the mid-ascending aorta, and that's what anastomosis. No kinking, no stenosis in anastomosis side. And you can see this is a case of, I think it's HVAD. You can see the alpha cannula take a very different course, and that's for instance, this is what Mahwash was mentioning. You see this stenosis, but you really don't know the physiological significance of this, right? So this is, and this is quite consistent with HVAD. Made you wonder if that long-term can cause any changes. So correlation with ICE will be very, very, very interesting. So this is HARMATE 2. You can see the inflow. This, for instance, in this case, the outflow cannula go around the heart, cross the midline, and go to the ascending aorta. And this one, the outflow cannula, go to the descending aorta. So, and we don't really know what it means, where you put it. I don't believe, the position, different position will have same physiological benefit. But again, this is some area that require more study. What type of complication, the outflow cannula, you can see this is a band relief disconnect that could cause some obstruction. And this is the overt kinking. So this is not a stenosis. This is just whatever reason, probably the surgeon ran out of the room and he didn't cut, or when the chest is open, there's more room. When the chest is closed, there's less room. So when he closed the chest, and you can see this severe kinking, and this patient obviously was doing very poorly with low flow alarm. And the extreme case of complete outflow cannula thrombosis, okay, all the way extending into the ascending aorta. And this is a patient with recurrent driveline bleeding, and he has a pseudoaneurysm in the anastomosis side of the outflow cannula with the ascending aorta, who would end up having endovascular coiling. Okay, but obviously you could have clot in both inflow and outflow cannula. This patient obviously doing poorly and require pump exchange, and I believe he probably made it. Okay, so the other thrombotic complication can occur as aortic root. Makes sense, right? Aortic valve most of the time is closed. You have stasis, and you have it could promote local formation of the clot. Traditionally, as we mentioned, the most commonly occurs in the non-coronary cusp because there's no coronary takeoff, so there's more stasis. But we review our cases, and obviously, I think 6 or 9 cases we have, there was 3 or 4 out of 9 occurs either in the left coronary cusp or non-coronary cusp or right coronary cusp or multiple. So this is a case with patient in left and right, and with more aggressive anticoagulation. 6 months later, the clot disappeared, but at the same time, she developed anemia, there's no hemolysis, and she has a passive stool. Made you wonder if she had ischemic valve. And so this is an extreme case, obviously, of the aortic root thrombosis, almost involving entire 3 coronary, and the patient does have evidence of myocardial infarction, but she was well supported, so she did okay. I think she ended up having a transplant. And the right-hand side is just very isolated, a good example of isolated clot in the left coronary sinus. And RV assessment, obviously, this is not something that we do routinely, but I think CT is a good alternative when you have poor transthoracic window. Not for acute assessment. I think it's important for study this smothering RV dysfunction. Get one at the baseline. Since a lot of patients have LVAD as destination therapy, so this allows you to have more accurate assessment, RV volume, ejection fraction, and hopefully with some new software, we can probably do RV strain. So you can see that it's a different way of doing RV function assessment. Infection, I think, fortunately, is not a very common occurrence. I don't believe we have too many cases. I really I can't find any example that we have here. This is obvious from some other centers, but with PET, I think this is your case, right, Mahwash from Mayo Clinic, showing that with PET, I think it will be our best way of diagnosing infection associated with VAD. Tamponade is very easy to diagnose with CT. It's extreme case of patient with LVAD and RVAD, and how much pressure is exerts over the heart chamber with almost complete collapse. And the indication of CT makes sense. It allows the visualization when it's valuable when imaging modality such as echo that cannot help or reveal the etiology. So going back to what Mahwash showed in the beginning, for LV unloading, I think transthoracic is is enough, and very rarely will require CT or TEE to look for LV unloading. For regurgitating lesion, I think transthoracic and TEE and ICE, CT might provide some insight in terms of long-term aortic valve structural changes contributing the progression of AR. But at this stage, we don't really use CT for assessment of AI. Clot, I think, is no-brainer. CT is the choice, the modality of choice, although you can do TE or ICE. But obviously, CT is a lot easier to perform if the renal function is acceptable. RV function, dysfunction, transthoracic, but in absence, CT or TE could be performed. For troubleshooting, we firmly believe a combination with transthoracic finding and CT offer the best combination in answering the questions, but obviously TEE or ICE could be helpful. For surgical complication infection, that's why CT together with PET could be very useful. Again, this is all I have. Any question? Question? Yes. Not to you. Right here.
TE versus ICE. Sounds like a lot of what you show with ICE could be done with TE. And I have heard speakers in other conferences where they say that they have almost given up on transthoracic and they do TEs for everything. For us, it would be a nightmare. With the number of LVADs echoes that you guys order, the TE lab would be flooded.
Just need a probe there.
But the question is, what makes you go to ICE versus a TE? Or is it just convenience because you're there in the cath lab?
So I think convenience for sure. So I think one is convenience for sure because, we have a catheter right there and the same French sheath, and we can just go through the IJ and do ICE imaging. One thing that I have been pretty intrigued by ICE is that your outflow graft, even though in TEE you see the opening of the outflow graft and you can get a good Doppler flow. But when I've seen that with ICE manipulation, we've been playing around with it quite a bit in the last couple of months when I was there, we could actually see a greater extent of the outflow graft. So that was helpful. And then I thought, like you said, other things you could probably get off of TEE also. But I think the outflow graph was something that was much. And then if you were looking more deeper into the aortic regurgitation issue, I think we should use ICE more because we're making a big decision on whether these patients need a TAVR or surgical AVR after their VAD.
I don't know if the sonographers are still here. Maybe they left, but at least we should know. What do you think should be the protocol for a ramp nowadays? I mean, we don't want to end up with 140 clips that we don't look at all of them. And the question to you is, I don't know, Are you looking at the mitral inflow truly? Are you looking at the TR jet truly? And if you're not looking at those, personally, I would look at the parasternal long and short, take a look at the aortic valve, the relation of the septum between the RV and LV, and I think that's plenty, unless you tell me otherwise.
I think, Dr. Zavgi, that's been a point where we've been talking about it a little bit, and I think some of us in the group particularly feel that, one, I think for thrombosis in itself, I'm not sure how often ramp is helpful to me to make a clinical decision. Like I said, I can diagnose if you're having an occlusive clot on the bedside by increasing your pump speed and just seeing your pulse. If it doesn't, if you still have if you're pulsatile, that means your aortic valve is still opening. And in particular, if they're in the ICU, you can look at the pressure and the arterial pressure. But the place that where it's helpful is by doing. Is it better now? It's okay. The place where it's helpful is where when we're discharging these patients and we want to make sure that they're not in clinical heart failure and they're unloaded appropriately. But you're right. I mean, we don't need all of those images, like a gazillion ones. So there is room to modify the protocol where we can just look at the parasternal lung, look at the LV diastolic dimension, the aortic valve, and the inflow.
Is it that important to go bam, 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 or could it be simplified by having a baseline, intermediate, and the most lowest level? I mean, what is the advantage of going through, 5 or 6 levels of ramping rather than just taking baseline, some intermediate, and the lowest that you are willing to go down to? Is there an advantage?
I think, I would recommend to you, not going to solve it today, but I would recommend some thought from this team, your team, to say, well, what should we do? And actually write it up, because people struggle with it. If we
we all struggle
and if the
with it.
field is evolving, I think we should have some recommendations.
Just one comment on that respect. Actually, we're talking to Dr. Jarudi the other couple months ago. Says we can use a stress echo as an example that we can have quads, and you have baseline and 3 levels of speed, and you have parasternal long,
Great
you
suggestion.
have mitral inflow, so we don't have to go through 140, maybe even 10 quads,
Yeah. The only time
We
that
call
I
it
think
Jarudi
is,
protocol, so. I mean, that will require, I think it will be a lot easier we have to scroll through.
After all, it is like a stress echo because
Exactly. Oh, that's right too, that's right too.
But Dr. Q, to your point, like the only time I worry about making too many speed changes is that you can have like that rapid septal interaction when the RV can just complete balloon out and fail. And, when we're not there most of the time, and these LAMP studies take us.
For safety reasons, it's better to go
Slowly, yeah. Because otherwise, if you go like 2,000 increments, next thing you know, the RV ballooned out and they're freaking out, the blood pressure is low and the, RV fails. And these are sometimes outpatient studies. So that's the only thing that I would say.
Very nice. Very good. Excellent.